Okay, thank you. Before I get started, I'd just like to thank the Hoof-Care Summit for putting on a tremendous program, and then Dechra, who actually sponsored the next two talks. My objectives this morning are first to review what is meant by the term navicular apparatus. Then I'm going to review the anatomy and physiology of the navicular apparatus. Then I'm going to give you the current thought on the pathophysiology of injuries to the navicular apparatus, with some of my bias thrown in there. And then lastly, to review kind of how vets will diagnose problems with the navicular apparatus. And I hope that information will help you understand, what's going on in your horses that you guys help manage that have problems of the navicular apparatus. Okay, so first, when we use that term, navicular apparatus, we're talking about the navicular bone, the navicular bursa, the deep digital flexor tendon, and the navicular ligaments. And I think that needs to be very important. Somehow, a lot of times people, when they hear the term navicular disease or navicular anything, they focus entirely on the bone, okay? And I think that's where, over history, there's been a lot of confusion and maybe argument about what happens and what's going on. So think global, navicular bone, bursa, deep digital flexor tendon, and the navicular suspensory ligaments. Okay, now I'm going to take you through some anatomy. I'll try to stay with the pointer here. This is the view that you guys see all the time, on slides, pictures, or diagrams. And it basically is a sagittal section of the distal limb of a horse. And I'm just going to review. I think everybody knows this would be the long pastern, the short pastern, the coffin bone, and then this structure is the navicular bone. Okay? And again, I think, unfortunately, we see this image so much. It's the image we even see on a lateral radiograph. It's shocking how many vet students, particularly, farriers, horse owners, think the navicular bone is just this tiny little square thing that looks like that. And it's not, and I'm going to highlight that to you. But also I want to highlight to you what that navicular bone or navicular apparatus is it's essentially, think of it as a kind of a palmar extension, a movable extension of the coffin bone, okay? So it's all part of that coffin bone. If it was welded together, it would be one piece. If you look up at the short pastern here and were to cut it off right here, you'd essentially have another navicular bone. And you'd say, why did the coffin bone decide to have a second little articulation? It's because it's to allow more movement through that joint than would happen through the pastern bone. So through evolution, we have them. The horse decided that was the most adaptable way for them. Okay, now I'm going to pull out the navicular bone. So this is just a navicular bone specimen. And so think of this as the shape. It's a canoe-shaped bone or a shuttle-shaped bone. It's not just that little slice that you see on the anatomy specimen or the radiograph. What we're looking at the navicular bone straight from the front. Okay, the bones, for reference, I'm going to talk and say that it has 4 borders. Okay, a top border, or what we often refer to as proximal, a bottom border, which is distal, and then an outside, which we'll call lateral, and an inside, which is medial. Okay, then it has what we're going to refer to as 2 surfaces. One is an articular surface, which is the front side. So that would be the front side here, which articulates with the long pastern bone as well as the coffin bone. And then the back side or flexor side, which is going to kind of oppose the deep digital flexor tendon. Okay, so 4 borders and 2 surfaces. What you can note, we're looking from front to back. The back side of the top border is kind of raised, and the back side of the bottom border is raised or more prominent. Those borders are where those navicular suspensory ligaments attach and anchor. Okay, so now we've just flipped the bone over and we're looking at the flexor side. Okay, again, the top is where what we'll refer to as the proximal suspensory ligament of the navicular bone attaches, and then the bottom you guys commonly hear called the impar ligament or the distal suspensory ligament of the navicular bone. Okay, now we've flipped it and we're looking at the top of the bone, straight from the top. Okay, so this would be the front side here, or that articular surface. This is the back side, or the flexor surface. And we'll just say this is a lateral border and this is medial. So here's the top or proximal border. You can see these little holes in the bone. Those are what we're going to refer to as foramina. Does anybody know why those holes are there? Okay, so that's how the vein, artery, and nerve gets into the top of the bone. Okay, because remember that bone is kind of free floating except supported by ligaments. So it has to get its vascular supply and innervation somehow. So now we've flipped it up and we're looking at the bottom surface or distal surface. So again, on the top here is going to be that articular side that articulates with P2. You'll see this little tiny facet on the bottom that articulates with the coffin bone, the back side, which opposes the deep digital flexor, and then the bottom, we're going to see a lot of bigger foramina. Okay? Again, those are just holes that the veins and arteries and nerves go in through the bottom of the bone. And just what so happens is there's more of those go in the bottom than the top. Okay. Now, we'll back to our little cut section. Does that make sense, that orientation? All right. So now, again, P2, P3. This white tissue on the ends of the bones, that's cartilage. And the cartilage of joints is what we call hyaline cartilage. It's the really smooth, kind of cushiony surface that allow us to move our joints normally without any thought or concern. Okay? And again, what you can see is that articular side of the navicular bone is covered by hyaline cartilage. The little facet on the bottom that articulates with the coffin bone is hyaline cartilage. Okay? Now this close-up view you should see more. You'll see a white tissue on the back of the bone or the flexor surface. That is cartilage as well, but it is actually fibrocartilage. All right? The difference between fibrocartilage and hyaline cartilage, they're very similar, but fibrocartilage is a tougher cartilage. So when we see that in places that have a lot of wear on them. Okay? Also, what you're going to see here are these spaces, and that is all coffin joint. And you're going to see a space behind the bone, and that's what we refer to as the navicular bursa. So the bursa, as well as the joint, they're both what we call synovial spaces. Okay? And those are tissues that produce joint fluid or lubricating fluid that nourishes the cartilage. Okay. So again, we have our bone, our bursa, and what you're also going to see on this close-up section is the little fibers of that impar ligament, okay, right here that come from that back bottom edge of the bone and then anchor onto that coffin bone. What you can see on the top is, again, a heavy white tissue, and that's going to be part of that proximal suspensory ligament of the navicular bone. And I'll highlight that in a minute, but the fibers from that you can't really see well here because they tend to go on the outside of the long pastern, and then they anchor up on the on the long pastern from the top of the bone to here. Right? And then again, what runs right back here is the deep digital flexor tendon. Okay? We've kind of purposefully gapped that open so that you could see the bursa, the space. but when the horse is weight-bearing, the tendon is completely against that flexor surface of the navicular bone. So deep digital flexor tendon coming down the back, opposing that flexor surface of the navicular bone, and then anchors just below where the impar ligament attaches. Okay. The bursal fluid and the coffin joint fluid, if you took fluid from both of them and didn't label which was which and gave them to a clinical pathologist, they couldn't tell you any difference. They're essentially the same. So bursal fluid is essentially joint fluid. We just call it bursal fluid because it's from a bursa. Okay, now a schematic, and this is just going to really emphasize the support of that navicular bone. So again, think of it as a palmar extension of the coffin joint, but a movable extension. So this black distal line would be the impar or distal suspensory ligament. And then this one above is going to be the proximal suspensory ligaments branch coming up to P1. So there's going to be a big branch coming up medial and laterally anchoring. So you can see that bone is really just suspended by those two ligaments, right? And then it is also supported by the deep digital flexor tendon on the back. Okay, does that make sense? All right, so I think while we're here, just take a second and think about the physiologic forces on the navicular apparatus. Okay, so where you can see it gets compressed, if we have weight bearing from the horse coming down the bony column, P2 is going to push down against the navicular bone here, and then as the deep digital flexor muscle tendon unit has tension, it's going to push up against the navicular bone. So it's kind of compressed between the deep digital flexor tendon and P2. When the limb starts to extend, again, you should imagine these give a little but not much. That navicular bone is under substantial tension, okay? So it can be compressed and it's under tension. So there's a lot of forces on it. And again, if you just look at this, where do you think the most pressure from the tendon on the navicular bone would be? Particularly, you know, after mid-stance as the body goes forward. It's going to be right here where this tendon takes the most severe turn, around this bottom third of the back side of the navicular bone. All right. Again, talked about levers and fulcrums. If the deep digital flexor tendon is the lever and the navicular bone is the fulcrum, this is the high wear and tear area. You could just imagine it from this picture, and what we know from evaluating horses with navicular disease, that's where we see all of the pathology, is on that bottom back side. Okay, just to highlight a little more, this is the vascular supply to the horse's distal limb, and again, the navicular bone is going to get its blood supply from branches of the medial and lateral palmar digital arteries. Kind of a little closer up view of that. Here's, let's for say, the lateral palmar digital artery, the medial palmar digital artery. We're going to have vascular innervation from the top going through those little foramina, and vascular innervation from the bottom going through those foramina. Okay, remember, whenever when I say vascular, there's always nerves with that. So vein, artery, nerve supplying that. And so then the next kind of question ought to be is, well, how do they get to the bone? And the way they get there is they travel through the ligaments. Okay, so here's an illustration showing a vessel coming right through that impar ligament and into the bottom of the bone, and one coming from the proximal ligament into the top of the bone. So again, you ought to sit there and think, man, anything that happens to that ligament could easily hurt those veins, arteries, and nerves. Okay. And again, if anybody has a question at any time, just please stop me. Now, a cut section. where we have put blue latex into the coffin joint just to show you its boundaries, and then red latex into the navicular bursa to show its boundaries. And this was done with some load on that limb. Right? So again, what people often don't realize is everybody thinks of the coffin joint from the front, but they don't realize how it traverses to the back and how it actually goes, again, between the coffin bone and the bottom of the navicular bone. All right? And then the bursa, when loaded, all that fluid is squeezed out where the tendon compresses against the bone and tends to sit proximally and distally. All right? But what you should note here, and it'll be important later when we talk about nerve blocks or therapeutic treatments, is how close those two synovial structures are. They're separated by only millimeters. Okay? So we used to think when we did this that they were, and they are, they're anatomically distinct. The blue didn't go into the bursa, the red didn't go into the joint. So we just thought they were separate. And then over the last 10 to 15 years, we've realized that that may be for latex, but chemicals like lidocaine or carbocaine, anesthetics, easily traverse back and forth. Medications like corticosteroids easily traverse back and forth. So if you see a vet injecting a coffin joint when the horse is thought to have a navicular bursitis, you'll understand why they chose to inject the coffin joint, and the answer is because it's easier, but they're assuming they're going to get diffusion of that therapeutic agent into the bursa, okay? Or even up into the bone, because we see how intimately associated those are. Okay, does that anatomy make sense and the physiology? All right. Now, again, to kind of, for the rest of this discussion, I'm going to break the problems associated with the navicular apparatus into what I would call classic navicular disease versus what we've become more aware of over the last 10 years is that a horse can actually have an acute injury, a sudden injury to any part of the navicular apparatus. And in my mind, those are two distinct syndromes or problems, okay? So again, a lot of confusion happens when people want to blend them. So the first thing I'm going to talk about is classic navicular disease. Okay, navicular disease has been recognized as a common cause of forelimb lameness in horses for probably 300 years. Okay. In one study, it was estimated to be the cause of a third of the lamenesses in pleasure or riding horses. Again, in my time as a veterinarian, navicular disease and laminitis are by far and away the two biggest lameness issues we deal with in the pleasure horse, adult pleasure horse. I believe this quote by Dr. Dick, quoted by Mr. Biden in the 1800s, he referred to navicular disease as the curse upon all good horse flesh. And again, it still creates a lot of anxiety and fear in people worrying about their horses developing this condition. Okay. It's generally accepted that navicular disease is a chronic, meaning long-term progressive degenerative condition that's going to affect at least one, but usually more than one component of the navicular apparatus. Again, over history, there's been a variety of theories about the cause and pathogenesis of navicular disease, but I think now there's general consensus that it is simply a degenerative disorder very similar to osteoarthritis. And before I forget, it's important to note, with almost any exception, when we're talking about navicular disease, it's the disease, the pathology is always on the back side of the apparatus, that flexor side, and then mostly related to that bottom part of that flexor side. That coffin joint side of the navicular bone is just, it's almost unheard of it for it to have any issues. Okay, so to highlight the similarities between navicular disease and osteoarthritis, I'm just going to go through a few anatomy specimens. This is 3 parts of a navicular apparatus dissected from a normal horse. So I'll orient you here. This is the flexor surface of the navicular bone. Okay. This is what would be its opposing surface of deep digital flexor tendon that would normally flip down and be right there. It's just been reflected up. Okay. So that would make this junction, that top junction, would be that proximal cul-de-sac of the navicular bursa. Okay, and what I'd like you to look here, this is the fibrocartilage. Again, it should be nice, and again, it projects a little yellow there, but white and glistening and smooth. That bursa is just perfectly smooth and happy looking. The tendon that rubs against this edge, this side of the bone, is almost a mirror image, okay, but should have nice and white and solid structure and fiber. So get that image in your mind, normal horse. Okay. This is a specimen from a horse with navicular disease. Now, the pictures I'm going to show you, I'm going to be honest, they're from the more severe navicular cases, but I'm using them just to highlight. So again, I think what you can see here easily is just, you know, any joint, you'd rather have that than that, right? Okay, so what we're seeing here is yellow discoloration of the cartilage. We're seeing marked thinning of the cartilage to where it's almost down to bone. And then here, this is a piece of tendon that was stuck to the bone. If you look up at that bursa, it's just very thickened and fibrotic. If you look at the tendon surface that was opposing this bone, it's frayed and fibrillated and torn, discolored, and essentially very, very diseased. Okay, so you can imagine that that horse probably wasn't very comfortable. Okay, again, another image of a horse with navicular disease. Flexor surface, and this is just a big chunk of tendon that was stuck into the bone. Okay, you can see the bursa is, again, very inflamed and fibrotic. We basically have to cut, that's what we call an adhesion. We have to cut that away in order to actually see the backside of the bone. For that to happen, for the tendon to adhere to the bone, that means we have full thickness loss of the cartilage, and then we wear into the bone, and then the tendon kind of starts adhering and sticking to it. So essentially, we've lost that smooth gliding surface that we take for granted. Okay, again, I'm going to show you a few of these just to drive that point home. Another pair of navicular bones. Same thing, massive adhesions of the tendon. Again, note, it's always down toward that bottom side of the bone where that lever fulcrum contact is the highest. And one last one. Okay, now, just to go a little further, this is a histologic section from that flexor surface of a normal horse, normal navicular bone. And what we've done is used a stain that stains for proteoglycan. And you guys have heard that term, but proteoglycan is a part of cartilage matrix that gives it its kind of resiliency and sponginess. And the pink will stain proteoglycan. So point here, it's being nice and uniform in that cartilage, lots of pink uptake, lots of proteoglycan, essentially very happy fibrocartilage. This is a section from a horse with navicular disease. And you can see that, you know, marked depletion of that proteoglycan, almost total loss of it. There's little islands of chondrocytes or cartilage cells that are trying to survive, but you've pretty much lost it. So basically the horse has lost one of its big cushioning and gliding parts of that backside. What happens, again, it's a vicious cycle, but when that happens, then there's more forces transmitted to the bone remodels, it gets thicker and more dense and fibrotic, and a lot of pathologic changes happen in this remodeling process. Okay, these changes, if you didn't know any better, they could be from a arthritic fetlock, would be the same kind of things, same kind of changes histologically. Okay, what we also know is that that all bones have pressure within them. So the blood vessels go in, there's a pressure within the bone, a normal resting pressure. And this has been documented in people and animals, but if you have arthritis and you get kind of modeling of that interior of the bone and fibrosis, the blood can't get out very well. It can get in because the in pressure is higher than the out pressure, so you get a higher pressure within the bone, higher resting pressure, and that's referred to as a higher interosseous pressure, and that has been documented to correlate to that dull, aching pain that people have with arthritis. Okay? It's even that pain that can change with barometric pressures. So when your grandma said something about her knee hurting because the barometric pressures changed, that's why. Okay, so that increased pressure inside the bone hurts. So navicular horses have that same increased pressure. So bottom line, everything points to it as being very, very similar to degenerative joint disease or osteoarthritis. So how does it happen? Now, for sake of discussion, I'm going to break this down into two very black and white scenarios. All right, and obviously, in real life, nothing works that black and white, so it's going to almost always be a blend. But for thought processes, I'm going to break it into two very separate scenarios. And the first that I'd like you to think about is that the horse has what we'd consider normal distal limb conformation, but somehow it has abnormal loads applied to its navicular apparatus. And then in a way that disease will result. Okay? So you could say, what would be abnormal loads? Okay, it could simply just be overuse. Okay, so think that the navicular apparatus is no different than a cannon bone or a muscle or a superficial digital flexor tendon. You can overuse those tissues and hurt them and cause disease. Okay, pretty simple. The second one, which I think is probably the biggest offender, other than Father Time, is what would be erratic use or the weekend warrior syndrome. And that would be the horse that doesn't get used except on weekends or maybe once a month. And again, you can relate this to many, I can relate it to myself, is occasionally I think I'm going to go out and start exercising, but for the previous 2 months I have not been exercising, and then I'm foolish enough to think I could go, play basketball or something, and I cause a lot of tissue trauma on that Saturday that I decide to do that. My tissues aren't trained and ready to do that because I haven't been doing it regularly. So just think of that navicular apparatus, the cartilage on that backside. The horse's, the body's nature is to only put so many resources into that cartilage. You can train and detrain cartilage. You can train and detrain bone. You can train and detrain the ligaments. You can train and detrain the tendons. But that training, meaning to allow the body to respond and strengthen, takes significant amount of time. So again, if the horse, for example, is used to just walking around the pasture 6 days a week, that's where it's going to kind of develop its kind of tissue quality. And then if it gets ridden 20 miles on Sunday, that's going to cause a lot of damage. Okay, other things, again, obviously Hard ground's going to transmit more concussion and vibration through those tissues. Again, in this day and time where we see a lot of overweight and obese horses, there's no doubt that that could contribute to the traumas on those tissues. I do believe, again, a lot of horses, it's just a part of aging. Okay, just like us, we can take care of ourselves, but no doubt most of us eventually are going to develop arthritis or degenerative joint disease, no matter how good a job we do. Okay, so that's one scenario I'm painting for you. The second would be where everything, all the loads seem reasonable, but the conformation is inferior, and it's the conformation that results in abnormal loading of the navicular apparatus. So, again, just examples that I believe will increase the trauma to the navicular apparatus: horses with very straight pasterns, horses with broken back hoof pastern axes, underrun heels. I think just moves the load that the horse receives, palmarly. Again, horses with large body masses but small feet. And then I'm going to throw into this is I do think that horses, just like fetlocks and stifles, can be born or develop with inferior cartilage to start with, or inferior bone to start with, that's at high risk to fail. Okay, so you've heard of the term osteochondrosis or OCD. It pretty much can happen anywhere in the horse. So the navicular apparatus, you could have similar defective bone or cartilage to start with. The bottom line is that somehow, some way, there's an imbalance between the stresses and traumas applied to those tissues and the tissue's capacity to withstand them. That's pretty much, though, a normal part of anything. But the problem is, and that's okay, as long as the body has a chance to recover, rebuild, maybe hopefully strengthen. But if this damage becomes repetitive and excessive, you're going to get disease. Okay? Fairly simple in my mind. Now, again, with navicular disease, again, we have to, again, so many people just think it's bone pain only. It's not. The pain could come from any component of that navicular apparatus. And again, in most horses, you could see from those pathologic pictures I showed you, very likely from all of the components. The bone, the bursa, the tendon, the ligaments. The ligaments weren't shown in those pictures because we had to cut them off to get that out of the limb. But I believe that they're traumatized just as well. So any questions on that? Okay. All right. Now, just a little summary. So when vets diagnose navicular disease, we use a lot of factors to come to this conclusion. It's going to be the horse's history, the clinical signs that we see, our diagnostic findings, which is typically from nerve blocks and some sort of imaging. And then we come to a conclusion the horse has a problem. So if you look at the literature, most of the literature would suggest in North America that quarter horses and thoroughbreds are at increased risk. If you were to look at the European literature, they would suggest warm bloods. Right? Now that we're getting a lot more warm bloods, probably if more studies were done in North America, we would see warm bloods added to that. Again, like it or not, seems to be increased risk if you're a male. Typical ages of horses affected are somewhere between 4 and 15 years of age. There's been, again, a lot of concern over hereditary predisposition. For a long time, we've believed that there was, but nobody had proven a certain genetic link. We knew that probably certain conformations were at risk, and that's heritable. Body size for foot size are heritable, and that sort of thing. But the Europeans, particularly in the warm bloods, have now found genes that increase the risk for navicular disease, and they're in certain breeds, of the warm bloods and even certain lines of those breeds. And they're really trying to drill down to see if they can identify specific genes that could be used to select against breeding those horses. So that would be nice. Horses with navicular disease usually present with an insidious onset of lameness, meaning that their owner would typically report, a history of reduced or poor performance, maybe a lameness that was apparent, but then the horse got over with a little bit of rest. But eventually they become lame enough, they seek veterinary attention. Okay? Navicular disease almost always affects the forelimbs. Occasionally the hind limbs, but it's very, very rare. Again, we believe that that's just because of the different loading and mechanics of front and hind limbs, okay? That's the reason it's predominantly forelimb. They're usually bilaterally lame in classic navicular disease, although one leg may be most apparent. The horses have a classic short, choppy forelimb gait. In a straight line, they may not actually appear lame if they're bilaterally the same, okay, or it may just be short and choppy. But typically when we circle them, they're going to be most lame on the inside limb, or it's going to exacerbate the lameness. Hard surfaces, again, will make the lameness more apparent in most cases. Okay. As far as our physical exam, most horses will resent hoof tester pressure over the navicular region, and most horses are going to improve markedly with anesthesia of the palmar digital nerves. Okay. So when we use hoof testers, we're going to apply pressure down through that middle third of the frog onto the navicular region. And the reason I think some horses don't respond to hoof tester pressure, it's very frustrating to some people and they don't understand why didn't they respond, is the use of hoof testers and how they're applied is extremely variable between people. There's so many different types of hoof testers. Some of them are hard to put that downward pressure with, and then there's a lot of variability in how they're applied. And I'll just use the vet students as an example. When they first are trying to apply hoof testers and you watch them, really the only thing they're doing is pushing the frog sideways. They're not getting the downward pressure that it takes to put pressure on that navicular apparatus. And again, those hoof testers are really just really strong palpation or fingers that allow us to push down just like we would if you had pain in your arm, and we're just putting point pressure to see if the horse resents it. Okay? Now, again, another reason for a negative response would be if the foot's long and the frog's long and the frog's really thick and keratinized, it's very hard to get pressure through that. A reason for a false positive would be if the frog is freshly trimmed or nearly scalped, any horse is going to resent that. Okay? So we use them as an aid and guide, but we should not get upset either way with them. But a positive response would be persistent and non-fatigable. The palmar digital nerve block. This is where we put anesthetic over the medial and lateral palmar digital nerves. Okay, so in this schematic, we would put anesthetic here and on the other side. And the good news is horses don't fake lameness. So when they hurt, they limp. If we anesthetize the nerves and they don't feel that part of their foot, they will not limp. Okay, so that's the good news. So when I said most horses usually respond markedly, again, reasons why horses may not respond totally, or reasons you may have to go to the next level up, is the horse doesn't always read the anatomy book. Okay, about 30% of horses will have a variant branch designated by this red branch that will innervate the navicular apparatus. So again, if I block here, the horse may get some better or no better at all, because it has a branch that I haven't blocked. We block right where the anatomy books tell us most commonly the nerves are. We cannot feel or find those variant branches. Okay, if I put anesthetic into the coffin joint, what do you think is going to happen to a horse that has navicular pain? Remember, go back to that picture where I showed how closely they were associated. Anesthetic will go directly from the coffin joint into the bone and into the bursa and will block their pain very, very quickly. So again, that's something we learned the hard way. We used to think that this was very specific for coffin joint pain and would eliminate the navicular apparatus as the source. So we now know that that is not true. You will block navicular apparatus pain very quickly. Okay, and then again, another way to, so we do use this though, we use that knowledge to treat navicular apparatus through the coffin joint. Okay, this is just a picture showing an injection into the navicular bursa. Again, we tend to treat that way sometimes, but because of ease, we prefer to do it through the coffin joint. This is a harder injection to do. Almost really should have radiographic control to do it. Okay. So again, if we have a horse with a history of that we suspect navicular disease, our physical findings suggest it. It blocks out to where we block it into the foot. Then we're going to go ahead and do some imaging. Okay. Radiography, almost every vet has radiography at their disposal. So that's our first imaging technique. And what we're going to do to image, radiographically image the navicular apparatus, we're going to take a lateral centered on the navicular bone. And again, what we might see, again, I'm not going to dwell on this, but a misshapen navicular bone. So this one is enlarged top to bottom. We know that's a pathologic sign. We're going to take what we call a 65-degree dorsal palmar view. And this is what that would look like. So here's our canoe-shaped bone. And what we're looking for, again, is this misshapen bone, meaning that there's extra mineralization where those ligaments attach to the bone. And then we can see these big loosened areas in the bottom of the bone. Okay, we don't know where those are, but they're probably enlargement and irregular shape of those distal border foramina. Okay, we know they get bigger and abnormal shaped with that pathologic modeling process. And then kind of our money shot is the flexor view or skyline view, where we shoot straight down the back, and what we're trying to do is see where that tendon, deep digital flexor tendon, opposes the navicular bone. And so what we can see in this horse is those big foramina within the bone, but we also see erosions and lysis of the back of the bone, which are going to tell us this horse probably has adhesions from his deep digital flexor tendon. Now, two things. Please remember that radiography is really only for bone. So we didn't see, we only really are imaging the navicular bone. We're not seeing inside of the bursa. We're not seeing the ligaments. We're not seeing the tendon. The only thing we're seeing is what effects they may have on the bone. Okay? Bone changes with navicular disease take a long time to happen. So when we see radiographic signs like that, that means the disease has been going on a long time and is very advanced. Okay? So the other bad news is you can see kind of some mild signs in pretty much any horse. Right? But really understand that if you have a horse that has a history, the physical findings blocks out like it, and then radiographs normal, that's actually a good thing, because that means at least we're not seeing bone changes yet. It doesn't mean the horse doesn't have bursal pain or tendon pain or cartilage problems or ligament pain. It just means the bone appears healthy at that time. Now, because the technology is pretty readily available now, and because a lot of owners just need to know, which is a good thing, and more can afford it, kind of the gold standard of imaging is MRI. And the reason for that is MRI can tell us about the ligaments, and it can tell us about the cartilage. It can tell us about the bursa, the tendon, as well as the bone. Okay, so if you can afford it, you can get much more accurate information. Okay? Again, not to dwell on it, but this is just an image, an MRI image, a sagittal image, and this white spot here is showing us that that horse has a problem on that flexor cortex. And this is a horse that we could not see that on a radiograph, but is very clear on an MRI. Okay, so does that make sense? That's classic or chronic, traditional navicular disease. Okay, now just what I want to finish with is what we used to confuse us, because when we would get a horse that, you know, kind of would be lame and we would block it to the foot, might resent hoof testers, but it would not switch limbs. I guess I should say, back to the diagnostic blocks, a classic navicular horse, we block one leg, and then the lameness is going to get much more apparent in its opposite limb. Okay? Because it just feels good on one side, then you really see how bad it was on the other side. Where this horse that we've learned about that has an acute injury, means perfectly normal today, goes out and you know, does a competition, comes back lame, they can actually hurt the navicular apparatus from a one-time event. Okay? They didn't have probably all that chronic wear and tear or stress, but something they did dinged one of those tissues or one or more of them. But they would block to one limb only and not switch. Okay? Radiographically, unless they broke their bone, they're going to be perfectly normal. So again, with MRI is how we have found these horses, and it's very excellent, and it will give you a very specific diagnosis, like the bone is normal, the bursa is normal, the ligaments are normal, but it has a small tear in its deep digital flexor tendon. Or the tendon is normal, the bursa is normal, it has a microfracture within the bone. Okay, so that is very important and a really useful thing that MRI has given us. So, questions? Hope that didn't confuse you.
Maybe this is like too much getting into it, but like of the products like OSPOS, that works if you have the degeneration of the bone. If it's really like the deep digital flexor tendon that has tear, that's not going to help at all.
Right. So the question was about OSPOS, and I don't know if you guys have heard of that. I'll give a plug. Dechra, that's one of their products, is a bisphosphonate, and it's a product that modulates bone metabolism, and the thought is it can help normalize pathologic bone metabolism in these cases of degenerative bone metabolism. So OSPOS would be indicated in a couple things. It could be used in the chronic horse to try to help with that bone pain that they may have, but in those acute cases, if they have microfractures or edema on their MRI, then OSPOS